thank you for coming back for the social science panel. I sat in for a small part this morning, and I recognize this afternoon really marks a bit of a shift in focus as we come to the final two sessions of the AGM, but I'm very much hoping it's going to be of interest to everybody and that we can have a really lively and relevant discussion. So we've organised the last two sessions in the interest of trying to widen out and look also towards interdisciplinary research oriented towards pandemic preparedness and response, and thinking about how a range of disciplines can come together, in fact, to inform policy and practice, but also to provide some critical insights into how some of these problems around infectious disease control are framed and understood. And so for the first panel, which is this one on social science insights for pandemic preparedness and response, we've assembled some social science leaders in this area of the study of infectious disease. And I'm first going to start by thanking them for offering their time to be with us at the AGM today, because this isn't the usual kind of conference we come to as social scientists, but we're very happy to be here with you. And we've all, in fact, worked on large interdisciplinary projects such as ZALS or some of the big GCRF hubs, and projects that really sort of focus on response efforts for the control of infectious disease. We've all worked with laboratory scientists, veterinarians, and indeed two of us are also medics. So we also have our own interdisciplinary backgrounds that we bring. And some of that work includes work on COVID-19. So there is a coronavirus emphasis. But at this point in the program, we're actually moving beyond that sort of organism-specific focus. And we're going to be talking more broadly about pandemic preparedness and response in the wider sense. And indeed, in the second session, before we close this afternoon, we'll be talking more specifically about interdisciplinarity and research. So just a quick indication of how this session is going to be organised. So we're sticking a little bit initially to a format of presentations as you've been having over the last 2 days. And so each of our four panelists have actually prepared short presentations, only about 7 minutes, quite short. And then after that, they're going to come and sit up here and we're going to move to a more interactive panel discussion and also hopefully involving questions from you as the audience. So my panelists are all social anthropologists, which of course reflects my disciplinary bias, but I think it's also partly because I'm aware that from the UK policy space and the experience of COVID-19 response, it's really behavioral science and psychology that has received considerable attention and important attention related to control in COVID. But in fact, there's a much longer history of involvement of the social sciences across different disciplines, anthropology, sociology, political science, but an involvement in scholarship on infectious disease control. And so I thought it might be useful just to give a little bit of a sense of that depth of engagement, but also to show how social and political science can really offer complementary perspectives. And that's what we're going to try and illustrate to you today with a set of presentations showing what we can bring both conceptually and practically to the space. So our panelists are going to start by sharing some research findings actually from projects. So trying to take you down to the sort of empirical level of some of the findings, our qualitative research findings, but an emphasis on insights that illustrate the value of a social science perspective in epidemic preparedness and response, not only just for informing policy or providing context for interventions, but also I hope to illustrate to you how we can also challenge dominant framings and also shift debates about kinds of evidence that matter and what priorities should matter in disease control. So that's our aim. We're going to start, in fact, with Professor Hannah Brown, who's a social anthropologist at Durham University, a long history of involvement in Lassa research and Lassa control. She's actually currently doing fieldwork in Kenya, which is very kindly joining us. So Hannah is actually live, but in the interest of not ending up a technology failure, she's actually recorded her presentation. So I'm going to now play that to you. And thank you to Lisa for enabling them.
Thank you very much for the invitation, and sorry not to be there in person today. I'm going to talk very briefly about how I see the role of social science in epidemic preparedness and response, and discuss very briefly an example from my own work in this area. Now, social scientists are often asked to provide information about context. It's assumed that by their understanding of context, social scientists can give information about human behaviours that drive or curtail epidemics, and usually in the case of anthropologists, such understandings of behaviours and contexts are linked to ideas of culture. It's thought that understanding these things better is necessary so people can be persuaded to comply with epidemic response or preparedness efforts. Now, most anthropologists would agree that understanding context is important, but for most anthropologists who work on epidemics, we don't really see either culture or context simply as ways to explain behaviour. And we're also particularly wary of assumptions that culture is a barrier to preparedness response because of the way this apportions blame on people, rather than starting by asking what people already know, what's important to them, and what they themselves think they need from preparedness and response activities. So let's look instead briefly at a brainstorm of some of the ways that anthropologists can and have supported epidemic response, and then come back to these questions of behaviours, culture and context a little later. A key contribution of anthropologists and other social scientists has been situating epidemic response in historical and political context. This means both learning from the past as well as understanding how past experience shapes the way that people engage with response and preparedness initiatives in the present. So, for example, if people in the past have experienced very brutal treatment from their government or primarily only neglect from health workers, they might rightly be very suspicious of responders from these organisations, as we've seen recently in the Democratic Republic of Congo, for example. Another contribution is that anthropologists can help us understand people's expectations around care and treatment. For example, shedding light on gender dimensions of care that are important to people, or the things that people need to do when someone dies in order to feel that they've properly managed that death and cared for the loss of their loved one. We can also explore as anthropologists how people see and understand outbreak response, including where tensions lie, and help responders to better tailor their activities to meet people's needs. And increasingly in the present, anthropologists also often work alongside or within vaccine development programs and other kinds of clinical research activities at all stages of the process, helping to better understand how communities receive these initiatives, engaged in community dialogue, and so on and so forth. I now want to discuss an example from my own work, which has tried to use anthropological approaches to address questions of disease transmission in epidemic contexts. So in 2015, I developed a theoretical concept with Anne Kelly, this idea of material proximities, which has been taken up quite widely in social science and other literature. So Anne and I wanted to move anthropological contributions beyond a kind of cultural awareness and instead explore how looking at the transmission interface ethnographically might be a useful intervention. So we were thinking when we developed this concept both about the kinds of meetings and forms of contact that take place between humans and animals in the case of zoonotic diseases, as well as the very different ways that people use protective materials in the cases of diseases that where these are used, and where fomites and other kinds of material objects have the capacity to amplify the spread of diseases. So the ethnographic work that then kind of followed on from this has indeed shown that infectious IPC materials like gloves and masks and so on, are used in relational and social contexts. These materials often have quite different meanings to different people, depending on the situation, or different meanings to different people at the same time. So we see, for example, in this quote that's from fieldwork that I did in Sierra Leone in December 2014, a health worker commenting on how the presence of a brother, a close relation in the health worker encounter, compelled that health worker to feel that she had to touch her brother, even though that was against the kind of no-touch policy that was around at the time. And we see this again and again. I've seen this often in my experience, like people not wanting to wear gloves to treat a friend or a family member because they think it's somehow rude, for example. So you may well think, well, this is obviously, more likely to be the case in resource poor settings where perhaps people haven't had so much experience in these kinds of situations or don't have good access to guidelines and knowledge. But these kinds of things are also true in the UK. In work done by anthropologists Sarah Pink, Jenny Morgan and Andrew Dainty with a multidisciplinary team of nurses, occupational therapists and others, these anthropologists show us very clearly that when materials like gloves and alcohol-based hand rub are used, they're also shaped by social contexts. So they recount, for example, one therapist who said she would very occasionally use the gel after she'd left a patient's house rather than during a visit because she felt that the patient might be upset if they thought she perceived them as being dirty. So their work also points to the affective and felt qualities of these objects. Describing, for example, how health workers could feel when the gel was not getting their hands clean and they needed to wash hands with soap and water. And all of this work suggests what is needed is not necessarily behaviour change or a better understanding of context in a narrow sense as a background informing behaviours, but a better understanding of these complex relations of material culture and affect and felt sense matter when it comes to IPC use, and including how they matter for innovations around those materials. So I apologise that this is a very quick and whistle-stop tour of quite a big piece of research, but I've slightly gone over. There's more information in these references if you'd like to read more for yourselves. Thank you so much for your time.
So, well, hello everyone. I'm Melissa Parker. I'm a medical anthropologist at the London School of Hygiene and Tropical Medicine. I'm going to talk very briefly about the Ebola Response Anthropology platform. So it actually builds directly on Hannah's talk, which, as you will quickly see, is a fabulous example of how anthropologists can usefully work with disciplines, with specialists from other disciplines, including clinicians and epidemiologists, in a very dynamic and iterative way. And in so doing, inform the delivery of humanitarian assistance in real time. So by way of background, the platform was established in 2014. At the time, Ebola was spreading very quickly across West Africa. In fact, modeling carried out by the USA CDC in September 2014 suggested that in the worst case scenario, there would be 1.4 million cases of Ebola in West Africa by mid-January 2015. Of course, there turned out to be nothing like that number of cases. I think the final number was just over 13,000. But these were very terrifying predictions. And in combination with pleas for assistance with global health leaders and staff running international INGOs such as Médecins Sans Frontières, underpinned a UN Security Council resolution which stated that the unprecedented extent of the Ebola outbreak in Africa constitutes a threat to international peace and security. So these were very worrying times indeed, especially as the biomedical cupboard at that time was virtually empty. Public health teams were being met with fear, and efforts to treat patients and limit population movement were lacking or backfiring. In fact, it was very clear that complex socio-political dynamics were profoundly affecting both the delivery and response to the humanitarian assistance on offer. So it was against this fast-moving background that a group of UK anthropologists and colleagues from Njala University in Sierra Leone came together. There was no time to do new research, so we decided to trawl through existing ethnographic research that had been carried out over decades across West Africa, with a view to pulling out salient points that might usefully inform the response. We also thought comparatively and drew on anthropological research that had been carried out in other parts of Africa on Ebola, most notably the Ebola outbreak that took place in northern Uganda in 2000-2001. So creating an Ebola response anthropology platform seemed like a productive way to proceed. What did we do? First, we established an electronic platform. It was designed with responders in mind. In other words, core pillars of the national response were mirrored on the platform, with tabs on community engagement, disease surveillance, case management, and so on. Relevant social research was then uploaded under the different tabs. We also did our best to connect with local and internationally based anthropologists, with governments, UN agencies, and INGOs. And underpinning this work was an endeavor to provide very clear, practical advice about how to engage with crucial socio-cultural and political dimensions of the epidemic, and in so doing, build locally appropriate interventions. It was, if you like, a new way of linking evidence to policy in real time. Momentum gathered quickly, and it often felt as if we were pushing at an open door when it came to discussing issues pertinent to both the design and implementation of programs seeking to halt Ebola transmission. In the UK, for example, the entire steering group of the platform were co-opted onto an anthropology and social science subgroup of the UK's government's Scientific Advisory Group for Emergencies, and we gave advice in Whitehall on a weekly basis. Typically, we were given a problem a couple of days before meeting with Chris Whitty, who at the time was Chief Scientific Advisor at DFID and running the UK response to Ebola. One such problem was this: people with Ebola are coming to Ebola treatment centres too late to be treated effectively. How can we persuade people to come forward within 48 hours of developing Ebola-like symptoms? A small group of anthropologists then came together, usually at a cafe in Waterstones next to Trafalgar Square. We discussed the issues intensely before walking over to Whitehall, where we talked through potential solutions with Chris, who has a training as a clinical doctor, as an epidemiologist, and much else besides. So what did we achieve? On the upside, colleagues contributing to the platform were hugely helpful in discussions about burial practices. As some of you will recall, burials were typically framed by response personnel as super spreader events. Globally, there was a strong focus on the culture of burials, including, for example, the practice of kissing corpses. Nationally, the response was often punitive. In Sierra Leone, for example, fines and laws were put in place to prohibit so-called traditional burials. But our discussions emphasized that in the majority of cases, practices involved in preparing a body for funeral involved more risk than attending a funeral. We also pointed out that there were a number of precedents for adapting burial practices, most notably where a body is not recoverable, or during the Civil War when large ceremonies were not possible. In other words, changing burial protocols was not necessarily problematic locally. It all depended on how the changes were introduced and who was authorizing the changes. And those kinds of discussions fed into the WHO's guidelines, which eventually shifted from safe burials to safe and dignified burials, with a massive subsequent impact on bringing people, encouraging people to come forward for treatment at Ebola treatment centres. But it was not all plain sailing. The second area where we were perhaps less successful concerned home-based care. Large numbers of people suffering from Ebola in Sierra Leone were being cared for at home by relatives or friends without external support. While we certainly agreed with the UK and Sierra Leonean governments that this situation was worrying, we disagreed hugely about what should be done about it. The UK government were not keen to support home-based care for two big reasons. One, they deemed it by definition almost as inferior. And a second major concern for them was that if they were to support home-based care, this might dissuade people from coming forward to seek more formal care in the Ebola treatment centres. But for us, that was profoundly missing the point. People were going to care for each other at home, whether the government or WHO sanctioned it or not. The salient comparison then was not between home-based care and the care provided at an Ebola treatment centre, but between supported and unsupported home-based care. Knowledge hierarchies and disciplinary ethics undoubtedly played a role in their reluctance to embrace home-based care. Subsequent research, and hindsight is a wonderful thing, subsequently revealed actually that our group were actually correct. This picture shows how villagers made their own PPE when Ebola hit their villages. And they did all of this under the radar of international and national responders. They were caring for people in forests, rehydrating them with their own homemade solutions, and using local materials to create their own PPE. In one village where we worked, mortality was actually less than that recorded at a nearby Ebola treatment centre. So if I'm to sum up very briefly, I would say, don't go anywhere without an anthropologist. I'll stop there.
Thank you, Melissa. So that gives a bit of the history, actually, of involvement of anthropology in policy and practice. And I'm now going to introduce my colleague, Syed Abbas, who actually originally trained as a doctor in India, worked for the Public Health Foundation of India, long history of involvement in zoonotic disease control and rabies control, actually. But more recently, he's been working on the large GCRF1 poultry hub, looking around avian influenza, and he's going to share those experiences with us.
Thank you, Hayley, and I hope everybody can hear me. It's nice to be here, and thank you for inviting me for this to this session. As Hayley mentioned, I work on the politics of One Health multi-sector partnerships. I come from a clinical public health background. I use a lot of ethnographic methods in my research, but just as a disclaimer, in this session, social sciences comprise lots of different disciplines, and the kind of insights I'm going to be sharing from my work about potential contributions to social sciences to epidemic preparedness and response are informed by my own experiences. So with that disclaimer aside, what contributions I think social sciences can bring to the table when it comes to epidemic preparedness and response? Social sciences and social scientists are mostly seen within a biomedical conceptual of the epidemic preparedness and response as facilitating implementation of scientific knowledge at the local level. This could be one of the applications, but social scientists, as I'm going to show, are able to bring so much more to the table. One key contribution from social scientists could be is in theorization, theory building, helping people think of complex systems and how they relate to each other, different parts relate to each other. what are the dynamics relationship between different components of a system, and what explains those dynamics and those factors. Theory building can also be think of as systems thinking in our reduced format. And for sure, this is not something that social scientists only do. This is something natural scientists do in, day out, even if this is not, the efforts are not recognized as such. What do social scientists do differently? We do theory building possibly by looking at asking different kinds of questions. We ask questions related to meanings, knowledge, understandings, as the first presenter showed today. When presented with the same set of facts, how is it that different individuals, different institutions, different communities come up with different understandings of the same phenomena? By interrogating assumptions of and different worldviews, social culture norms, we're able to parse the hidden meanings, which inform what makes people think the way they do, and how can we link this thinking and these understandings to their actions. And the second set of questions that we ask is about power. How is power distributed across within communities, between different institutions? Who decides what the priorities are? And how do different actors navigate these power hierarchies? Some of this might be sounding a bit abstract to this audience, and my apologies for that. Let me draw upon some practical examples based upon my work around One Health governance. So One Health, as most people in this room, I think, are going to be familiar with, refers to a concept wherein they say that animal health, environmental health, human health are all closely interdependent. Sounds good, right? But what does it mean in practice? If we have to have One Health interventions, what might that look like at the international level, at the national level, at the sub-national levels? So, drawing upon some different pieces of work that I have been doing, starting with what One Health might look like at the national level. For many of the countries you go to, different One Health sectors, animal health, human health, whatever environmental health might mean in different contexts, they're assigned to different nodal ministries. And all of these sectors are operating under different incentives. And these, to take an example of India, where I come from, almost all the public health activities are under the purview of Ministry of Health and Family Welfare. Health is a expenditure incurring ministry. The primary goal and primary incentive is health protection at almost all costs, to a large cost. The government is willing to spend a lot of money to protect the health of its people. When it comes to animal health, as a lot of people in this room know, that even though a lot of focus on animal health is on food safety, around zoonosis, around risk mitigation and biosecurity, but these have to be balanced against the cost of production. Ministry of Agriculture, which is the nodal ministry in India, where I come from, is not an expenditure incurring ministry. Its job is to contribute towards country's economic development and growth. So the resources, they're working on different competing incentives. Sometimes these incentives and worldviews might actually conflict with each other as well, and which means that when it comes to designing One Health programs, they work in different ways than the way they are largely designed. To take a slightly different example of operationalizing One Health around AMR. The UK Fleming Fund program is a huge globally funded program working in 24, 28, now I think it's 29 different countries, spending hundreds of millions of pounds, I think 240 million pounds in the first phase. The whole ambition of this program was to establish AMR coordination committees, interministerial coordination committees at the national level in all of these countries, according to the WHO Global Action Plan for AMR. These coordination committees would rely upon data generated by sectoral labs, and these committees will provide the venue for cross-sectoral analysis and cross-sectoral decision making. But what actually works in practice is quite different. One size, unsurprisingly, does not fit all. Some countries, such as Indonesia, have a very decentralized form of governance for good reason, given their history and authoritarian rule in the country. The data generated are owned by the provinces in many cases. When it comes to coordination across different ministries, these are there's a supra coordinating ministry, which can convene AMR coordination, which can convene cross-ministerial dialogue, which means AMR coordination committees cannot exist in a country like Indonesia. On the other hand, you have countries such as Bhutan or Papua New Guinea, where almost everybody in positions of authority know each other through social networks or family networks or professional networks. So data sharing takes a different route and a different role, even within resource capacity constraints in these countries. So which means that a single Fleming Fund program following a single template from the WHO Global Action Plan cannot be implemented in the same format in all countries, which means midway in the program, they had to redesign what the program might look like in different countries, and to tone down their expectations about what kind of One Health might be possible in different countries. Coming to sub-nation level, an example of what One Health might look like at the sub-nation level and what social scientists might do to be able to address it. Taking the example of Bangladesh, where I've been working in the last couple of years, they have a new breed of chickens called Shonali, which is a colored chicken. Colored chickens are understood by large majority of people to be indigenous breeds, which are supposed to be healthier breeds, as opposed to the white feathered broiler chicken, which is produced through intensive large farms, commercial farming systems. So people prefer colored breeds, even though these Shonali chickens are actually mixed breeds. These are not really indigenous breeds. And the problem is that these Shonali chickens are bred in small and medium-sized scale farms with much poorer biosecurity, much poorer hygiene practices, and possibly much more risky, and possibly are much more risky in terms of production, retail, and consumption. But when you speak to when I went and spoke to the veterinarians and the animal husbandry services, informally the government was much more government was promoting Shonali chicken as a way of providing employment and to keep people off the streets to keep people off the streets and gainfully employed, which any further restrictions, even a small changes in regulation might have had adverse impact in the government's point of view of how of law and order, possibly people coming onto the streets. That's the word. That's the phrase which is used by the Director of Livestock Services. And as we saw in the last couple of months, things were obviously reaching the boiling point for lots of different reasons. So how do we combine? How can given this complex, given the fact that all these complicated phenomena are intersecting social phenomena are operating at different levels when it comes to One Health drivers, how can social scientists contribute? We are trying to do so by going back to my original proposition. Social scientists can contribute towards theory building. So what happens? So one of the projects we are right now running is conceptualizing is about what is an intellectual hypothetical exercise. What happens if you are able to get access to different kinds of data sets across human health, animal health, and animal health, human health, environmental health? How will this all fit together? And how can this be modeled to be able to make better decisions? So social science, I think I should have made better notes. But the point I'm trying to make is that we will all like, as researchers, we would all like to get more information. But is it possible that the data that already exists, that we already have, how can we make better use of the data that already exists to be able to make better decisions? In social sciences, we're very good at trying to bring together different points of views. And this means convening debates across different disciplines. This means convening debates, having people different interests and different worldviews. This also means being able to convene debates across different disciplines. So when it comes to convening interdisciplinary dialogues, maybe that's something that we can it's a service that we can offer as social scientists as well. Thanks very much.
So, let's move to our final presentation, which is by Professor Christos Lynteris, who's come just down the coast from St Andrews, but has a long history of working, in fact, in China, very relevant work, and he's going to tell us about his work on rats.
Yep. Okay, I hope this is working. So hi everyone, my name is Christos Lynteris. I'm professor of medical anthropology at the University of St Andrews, and my aim here is to be a little bit provocative around the notion of behavior. Now, anthropologists are traditionally asked to translate. It's usually a translation of one culture to another, but when it comes to medical anthropology or anthropologists' work in the field of epidemic response, we are more or less asked to translate ethnographic data into epidemiological evidence. And in particular, we are asked to identify behaviors and practices and also contexts that function as drivers of zoonotic or human-to-human infection, and also the ways in which these may be changed so as to reduce the risk of infection or spillover. Now, both describing behaviors and advising behavioral change in this way usually comes under the rubric of something you've already heard about, which we know as culture. Now, this raises significant questions within the discipline of social anthropology in general, and medical anthropology as a sub-discipline in particular, a very well-structured sub-discipline, I have to say. Now, questions like this, which we've posed for quite a while now, is what is being lost or produced in the process of this translation of ethnographic data into epidemiological evidence? And what happens when we take this translation from the very start as the aim of anthropological research or work? How does this change the research we do on the ground and the interaction with our subjects, informants, or participants, any way you want to call them? And more broadly, how to deal with a systematic demand for culture from the side of epidemiologists and doctors, when in fact the term is largely an embarrassment within anthropology itself, which is very quickly abandoning it as being a platitude or something which mystifies more than clarifies our understandings of social and interspecies relations and complexities. Less discussed, perhaps, than these big theoretical questions, and on a more pragmatic aspect, anthropologists' exchange with epidemiology has a very, very neglected problem, I think. And this has to do with a focus on behavior and behavioral change, which in my own research I have found to be very, very limiting. So I will give you, as we all have, an example from the field. And this has to do with an ethnographic project I'm leading, which is part of a much larger Medical Research Council funded project, which involves epidemiologists, other life scientists in the UK, Tanzania, and Madagascar, including the Institut Pasteur, with the aim of developing effective and community-led approaches to rodent control in rural areas in Tanzania and Madagascar, which are affected by leptospirosis and plague, both rodent-borne diseases. Now, initially, the idea behind this collaboration was that we, as anthropologists at St Andrews, would provide the life scientists and the local authorities through a 12-month ethnographic fieldwork in Tanzania with, if you like, a behavioral portrait of rural communities in the Morogoro area in Tanzania, which would then allow our local partners to design effective interventions to limit the risk of rat-borne leptospirosis. And this research on the ground was led by Dr. Caroline Buru at St Andrews under my supervision. But what we soon discovered from the field was that something that we did not expect, given the literature and the ideas that the scientists had provided to us. And that was that locals, so people working the land, were both well aware of leptospirosis as a disease and its mode of transmission, but also they were very well equipped with controlling rats. They knew how to control rats, how to avoid contact with them, how to rat-proof their farms, their houses, etc. Hence the question arose, why are there so many outbreaks? Why do we have so many cases? If the locals already know everything that we went there to teach them, supposedly, what's going on there? And what we found out that was that the drivers, if you like, of leptospirosis infection in the region had nothing to do with behavior or culture, and everything to do with the agricultural and land economy in Morogoro. Which I'll try to explain very, very briefly. Now, this is the locals engage traditionally in rice cultivation, dry or wet, and for many, many years they had been developing different methods for controlling, trapping, poisoning rats in order for both to avoid rats eating their crops, obviously, but also to avoid infection. But since the introduction, with the collapse of Tanzanian socialism, of structural adjustment reforms, their plots became very rapidly surrounded by vast monoculture sugar plantations, where rats thrived, because rats love this crop, while the corporations themselves, being so huge, couldn't be bothered with controlling them, because they were not losing enough crops, given the vast extent of these monoculture farms, for them to be worth controlling the rats. Now, what happened, of course, was that when you have a small farm of rice surrounded by huge sugar plantations full of rats, the rats eventually invade your rice fields. They both eat the rice and invade your storage spaces and your homes, vastly increasing the risk of infection. And there was nothing locals could do to control the rats, although they very well knew how to use the traps and poisons and rat proofing. This didn't work given the scale of the problem. Then what the locals, or many locals, did was, in desperation, they abandoned their own lands, the lands that they owned, to go somewhere else as hired hands, or more often renting a land in a place that would not be surrounded by such plantations. But then they soon found that if they were to employ their rat proofing and rat control practices, the ones that they were very well aware of, such as clearing the bush in order for their farm to not be rat infested, then the following year, the landowner would take over the farm and wouldn't rent it again, because the farm would be so good that it wouldn't be worth renting. They would cultivate it themselves. So there was a very, very concrete economic, if you like, incentive or disincentive to control rats in the region. So knowingly, they let the bush grow. They let their land being not so well cultivated or not so well rat-proofed, so as not to lose the lease of the land. Hence, in this case, I think we have a very, very clear situation where, in spite of all our good intentions of the project to introduce new trapping methods and new traps and what have you, none of these behaviorally focused research and practice would have any concrete impact unless the land economy and the political economy were to change, which of course a research project funded by the MRC or whatever is unable to do, because this is a large-scale socio-political and economic situation. And this, I think, is a very important discovery, if you like, or insight. It's a very clear case, because it makes the limits of behavior as an analytical framework and behavioral change as an aim very, very clear. And more than that, it makes the need for an anthropology which focuses on structural, economic, and land economic relations rather than culture, as it were, very, very important. There is, again, a disincentive when it comes to anthropologists to engage in such research, because, well, for anthropologists themselves, it sounds very boring, right? I have to be honest. It doesn't have this extra kind of aura of cultural or if you like, ritual or other multi-species aspects that fascinate anthropologists. But there is also the the disadvantage of how anthropologists look to our life scientist partners, right? We do not carry this mystique of the anthropologist, which unfortunately has been built since the 20s and Malinowski to today, as people that engage in incomprehensible behaviors, right? Because that's what we're expected to do, to engage with behaviors that normally scientists wouldn't understand, and they need to translate it. Here, we don't need any act of translation in order to understand a very, very concrete political, economic, and land economic relation, which limits rat control very systematically and hence promotes rodent-borne infection in a deprived area of Tanzania. Thank you.
So we've got a little more time, and I'm actually going to just quickly ask the panelists to come up, and because I know their work, I'm going to ask each of them very quickly in a minute to shifting the discussion quite specifically to the kind of implications of this kind of research for policy and practice, because I know that's the interest in the room. I'm going to ask them all, and they have sort of been warned, to reflect on some other bits of work they've done, and sort of how they have engaged also with both other disciplines, but also with policymakers. And I'm going to start with Melissa, who in fact was one of two anthropologists who sat on SPI B SAGE, government SAGE, during the COVID pandemic, which was a very interesting experience, and indeed also working in a complementary way with behavioral scientists, with psychologists, who we see as being part of a different discipline. We see ourselves as anthropologists as occupying a different space. So I wonder if you could reflect on that experience, what you thought social anthropology brought in COVID-19 in the UK, given the sort of history of engagement in Ebola, which is sort of out of the UK, and there was a bit of a sense that anthropology wasn't going to be relevant in COVID-19 because anthropologists only worked out there, but we see ourselves very much as contributing to research on social life everywhere. So do you want to just briefly in a minute reflect on that experience and the sort of complementarities with behavioral science?
The complementarities.
Yes, constructive.
Yeah, it was an entirely different experience, actually. So much more mixed, I would say, than working on the Ebola outbreak, for all sorts of reasons. One is that the politics shaping the work was entirely different. So for the Ebola outbreak, it was not a politicized issue here in the UK in the way it was a highly politicized in Sierra Leone, but it gave the British government a lot more scope to be flexible, adaptable, to listen, to respond. Whereas in the UK, we have these different, as I'm sure everyone is aware, all these different SAGE committees and subcommittees and sub-subcommittees, and there were literally hundreds of people from all sorts of disciplines involved in different ways. And then within the social and behavioral science group, it was a huge group. So on a call, you could have like 100 people, you know, ranging from very quantitative social psychologists to people who would only, well, there's only one of us who done epidemic work, I mean, I've done other kinds of work. But it was a huge spectrum of people working with different theoretical ideas and so on, many of whom had had no experience of working with policymakers. So that in itself was, the group dynamics was a challenge. But I think we were given questions in the way that we were during the Ebola outbreak. So typically we would get an email marked official draft essay question. It was a bit like being an Oxford undergraduate or something. Answer expected in 1 week. And it was like, explain why mortality from COVID is so much higher among a particular ethnic group and what you would do about it. And then we would have to produce a report and we would argue over the actual summary more than the content, because we knew that a minister was only ever at best going to read the summary. So that was quite a full process. But I think what it highlighted is how much evidence, a huge amount of effort went into it, was not heard. Like the politics overshaping it. It's not at the ready. You can say as much as you like that people need to be paid to self-isolate, but they will not hear. So it was a frustrating experience in a way that working on the Ebola outbreak was not, because both government and national government wanted to hear. So it's also that interdisciplinarity, I suppose, is needed not just among researchers, but also among policymakers who feel competent to hear and make sense of diverse kinds of evidence. Yeah.
Thank you. Hannah, can you hear me? I hope so.
Yep.
Lovely. The dangles of the mic. Thank you. Hannah, I know you've worked for a very long time on Lassa fever and Lassa control, also actually sharing the rodent piece with Christos. And of course, as we know from another conversation, your expertise is now very much in demand also with SAPI, about to do a vaccine trial for Lassa, and indeed that work also is really relevant to MPOX. So I wonder if you could just reflect to the audience on how you found your anthropological research contributing to some of those debates, particularly from your Lassa work.
Well, I think that probably one of the really, really great things about anthropology is that we take time to listen to people and to talk to people. And I think, part of what was coming out in Christos's talk was that really the kinds of assumptions about what the problem was were quite different when he spoke, he and Caroline Mburu spoke to people in Tanzania. And I guess I would say something similar about what's going on with Lassa fever. When we talk to people about rodents in Sierra Leone, really the problem that they were most concerned with was not actually Lassa fever, it was economic survival, and it was the fact that rodents were eating their food, sometimes also their clothes, even money, damaging things in their homes and creating a kind of economic insecurity. And to my mind, that's somewhere where I'm really, really, as a social scientist, still wanting to push people who are kind of trying to manage Lassa fever to think about kind of rodent control within this kind of landscape of kind of economics, not just as a kind of health concern. And similarly, when we talk to health workers, a bit like Melissa's example, I suppose, about home-based care, health workers outside of the main centre where Lassa fever was treated told us again and again, we're qualified health workers. We want to be able to train so that we can treat people who have Lassa fever in our hospital. We don't want to have to send them across dusty roads for an hour to the specialist centre, which is in Kenema. And is actually outside of the endemic region for Lassa fever, but for various kind of political reasons has become the specialist centre. And I still feel like these concerns aren't really kind of mainstream in the response to Lassa fever. So that's where I think, as social scientists, we have to keep kind of banging the drum and showing how our research allows us to find different ways of maybe conceptualizing, okay, so if Lassa fever is a problem, what kind of problem is this? What matters most to people? What kind of changes do people want to see? And not assuming actually that we, because we're experts, whether it's in anthropology or even in, biosciences, that we know really what the parameters of the problem are without questioning those. I hope that's enough, Hayley.
Thank you very much. And Abbas, continuing this point about, because I know it's been very much part of your work about livelihoods and what matter to people, maybe reflect on your work in Bangladesh and what kinds of inputs you feel have really come from the social science work into sort of avian influenza control in the livestock industry.
Thanks, Hayley. Let me take the question a little bit on the decision-making side. So in my interaction with decision makers, everybody likes to use the word One Health in their, when they're making a case for a program or funding within their own departments, as researchers in our own disciplines, to our own funders. But it's very difficult for somebody who's a director of animal husbandry or a director of public health to be able to link what they're doing with, for example, there's the sourcing theory that the sources of lots of infections for zoonosis are the animals coming in affecting humans, which is not always true, but to use that logic, public health directors are not able to link the burden of public health problems with that of sources coming from the animal health side. So if we as social scientists are able to help them convince the discussions, show them the data that is already there, help them make sense of this data in a way that is approachable and understandable to them, then I think it'll be quite useful to them in their own decision making, and perhaps it might make a useful case study for us as well.
In a way, you're talking about doing that translation work that Christos was talking about. So Christos finally, Christos has actually done a lot of work in China and was kind of pulled into COVID discussions around wet markets and control. And I asked him if he would talk a little bit about that work.
Sure, yes, thank you. So, yeah, I first worked in wet markets during my PhD work. So that was 2007-8, when I was an intern at the China CDC in Beijing, and we would regularly inspect wet markets, or what we call wet markets in the West. So I had a very, very different image of these markets than the ones reproduced in Western media, where you have these quasi-miasmatic representations of them as, place where infection festers, in a very early modern kind of conception of infection, I think. So I was really struck again, when this image popped up again in the media. Very interestingly, I have to say, just as a footnote, using images from 2003 rather than actual images from wet markets today, without anyone mentioning that these are 15-year-old, 17-year-old images. So what struck me first was this very, very systematic entanglement of Orientalism and xenophobia with fears of emerging infectious diseases, which I think makes any rational discussion of disease emergence in China impossible in the West, because Western thinking is so corroded by xenophobia and Orientalism, especially when it comes to our epidemic imagination since the 19th century, at least, that it becomes really, really difficult to have a rational kind of argument. But then, very pragmatically, and that was my intervention, rather than just accusing all of us of xenophobia, which is kind of an obvious thing. My practical intervention at the time was that there were always calls of shutting down wet markets. And in my experience, the practical impact of that would have been that so-called wet markets would just go underground. You would have hundreds of thousands of illegally functioning markets without any regulation from the Chinese CDC or anyone, hence actually increasing any risk of infection rather than reducing it. Because banning live animal markets in China is like banning supermarkets in the West, right? It's just not going to happen. It will never happen. Right? We just need to forget about that. It's not just epidemiological imperialism to think that. It's just impossible, practically speaking, right? So I don't know why people entertain these fantasies, but the net effect of that, and that's what happened briefly when actually the Communist Party in China during SARS in 2002 and 3 tried to shut them down, is that all these black markets flourished completely out of control, with much worse conditions, because people were in a hurry, they were hiding things, they couldn't maintain the conditions they properly maintain, which are not ideal, of course, but selling raw milk in the US, across the US, with H5N1 is not ideal either, but no one is talking about shutting down dairy farms in the US, right? So I think, our argument with Lyle Fernley at the time was that we need to, keep a cool head and understand how things work in China, and propose something which is both as much free from Orientalism and xenophobia as possible for us in the West at this stage, and something that would work and not make things worse.
So we have about another 15 minutes or so. I'm going to open it up to questions from the audience. Go ahead. And we have a wonderful microphone runner, and we're going to have to pass that microphone.
I'm quite loud. I can give that microphone.
Okay.
So, I wanted to ask a question about this. What Christos said is very similar to what we see in other areas of specialty. So in digital and data, we are very interested in the idea of actually doing user research and finding user stories and user needs before we try to answer the question. We go to see what it is that people actually need on the ground. And your sort of description of that first step of, well, let's have some anthropologists in to help us sort this out, because obviously the people need to be taught rather than going and asking them. It is something that seems to go across all of science. And I wonder if there are other places where, in relation to the One Health idea, where we are making assumptions that are based on outdated models. And I'd like to ask the panel what they think about the idea that if we continue to talk about One Health, we find ourselves inevitably forced down the medical model of well-being. Whereas if, for instance, we talked about One Health and well-being, then we could consider what is it that we need to survive as people and as animals to be not just healthy but happy. Because if you isolate someone, you keep them free of disease, but they don't live.
Very interesting thought. So you reflect on that. I'm going to collect some questions. So reframing One Health. Yes, go ahead.
Panel would like to answer how best to challenge fake news. So how should scientists communicate their science so that it overpowers fake news?
That's really interesting, because actually quite often anthropologists are brought in precisely in this context of dis and misinformation to do this kind of role of translation, and then it's possibly also reframing what is fake. But I'll leave it to my panelists. And wonderful. So who was first? Let's go right at the back and then we'll come down. It's Julian up there in the dark. Can you shout, Julian? Except I think Hannah can't hear if we don't use the mic.
No, okay, it's a provocation. So for declaration, I was a co-opting member of NerveTag. NerveTag now, properly. And I think it worked really well. Peter did a great job chairing, but we were all of a similar type of person, either working class to middle class or middle class, right? There was not one person on NerveTag who I would say was a normal person who actually did things. And I'm going to put to the panel that, do we need more normal people on these types of panels? And I'll give a humorous example, which I don't think is telling tales out of school, because David was in my kitchen at the time, getting moderately drunk with my wife when this problem came up of it's not unusual, is it? The alpha variant, right? So the alpha variant started emerging in 2020 in September, just when students were going back to university. And so the behavioural people said, oh yeah, the students going back, they'll all obey the rules, you know, they're educated kids. And we just looked at each other with like, are you having a laugh? Because these are kids fresh out of home, they just want to get drunk, have sex, you know, all the things that people actually normally do. And so I'm just wondering, is there a case on panels for like normal people to be included to like bring people a dose of reality without losing my position on any said panel?
Very interesting question. Class in Britain. Okay, why are people on panels? Here, and then we'll go to Stalin. And then we'll come back to the panel just for a final round. You can choose what question you want to answer. Melissa, you might want to comment on Julian's question.
Julian, to your question, if we need more normal politicians. I think there was no shortage of good evidence.
I guess my question is sort of a follow-up, but not quite framed like that, but it's basically around the messaging of like we had these sort of initially, I'm thinking COVID, you know, washing hands and then switching to masks and socially distancing, and it's tricky, right, to navigate through that sort of changing of policy, people not seeing it, not buying it, or be like, oh, you're going back and forth with it, what's the science and whatnot. Just trying to get your perspective on this sort of communications of various policies that may change over time and how you would navigate it, depending on age as well as just generally like the younger kids to going to school, how you might approach policy decisions towards those rather than the elderly, for instance, that sort of thing.
So just to get you correctly there, sort of what social science can contribute in sort of communicating uncertainty in the context of Panellists. Yeah, that question of uncertainty, I think, has occupied many of us. Darren, go ahead.
I had a question for Dr. Abbas, actually, which was what you were saying about what motivates like a health department versus an agricultural department. Reminded me a little bit of the book Sapiens by Harari, and what motivates research funding is often this sort of short-term gain. And it seems to me that the One Health idea was almost to try and reframe that funding landscape to try and include like agricultural and environmental health on the same platform as human health, but it seems to have sort of failed in sort of redressing that balance. I think you're totally right that it's still animal health. Sorry, human health is still, we will spend whatever we can to solve this problem, and agricultural health is making the sort of cost benefit analysis. But you know, with climate change and land use change, it seems that all the things are so tied together, and we all agree that. But I think we failed to communicate that information, and you know what the net benefit really of a One Health agenda is. But I guess my question is, how do we go again at that and convince people to sort of see the three things on the top step?
Okay, well, let's do another round of responses. Christos, can I start with you? Remembering the question, very interesting question about.
Yeah, sure. I mean, I think with Steve here, we have someone who knows who does a critique of One Health much better than I do. But I mean, one of the key things, one of the key problems for me with One Health is this very narrow understanding, you know, of what is an animal to the people that we are addressing, right? I mean, animals are pretty much fixed things for our society, yeah, like this room, but they're not fixed or the same thing for other societies, right? So rats are not just rats, right, in a Tanzanian context. In the same way that rats are not rats in, I don't know, I have a PhD student who is studying rats and leptospirosis among the Guarani. Rats, depending on which rats we're talking about, whether they're rats which are indigenous in the village or rats that come from the city, can be different things. Rats from within the village can be ancestors, they can be spirits, they can be all sorts of things. Rats coming from the outside are just horrible things that the white people are bringing into the village. You know, it's very simple. So here is where One Health becomes very complex, right? When we don't have humans and animals, each being analogous mammals or organisms that have a common trait, which is called health, and another common trait, which is called illness, but we are facing societies where, you know, these things are much, much more complex. And health is not necessarily a good thing, right? Some animals are better if they're not healthy, for cosmological reasons, for sociological reasons. Then One Health can be a really, really problematic framework, A, because it doesn't make any sense to our participants, and B, because it imposes a model that they will only see as an imposition and as an externally kind of like a demand made on them by the state, to which they're necessarily suspicious because of all the history of how the state has been treating indigenous groups. Right. So One Health is inherently problematic for these reasons.
Thank you. The critique of One Health, I suppose quite a lot of social science literature, and indeed we have Steve on the next panel. Abbas, very briefly, if you will, because we've run out of time. Yeah.
Thank you. Just very quickly responding to your question on framing and well-being with regards to One Health again. Almost every single year since the term One Health was coined, people have tried to come up with new definitions. Most recently, the WHO Theory of Change and the new One Health high-level expert panel, quite a mouthful, their definition seems to be making a nod towards sustainability. So it's much more inclusive than the previous definitions that have been come around so far. But when you look at One Health Joint Plan of Action from WHO, for example, they have failed to put that in practice because they're focusing just on human health outcomes. Again, the suggestion of using well-being as a reference is very well taken, and that's been considered in some other spaces as well, especially those which are concerned about sustainable livelihoods and environment. So again, that's a theme that we should definitely be pursuing further. That's my feedback. And to your question, I agree with you. It's difficult, but hopefully social science can offer a way to convene dialogues and debates across different disciplines, and I'll be happy to discuss further ideas around this with you.
Melissa, any final thoughts about expert panels and messaging in context of uncertainty?
I suppose, I mean, other than the obvious, which is there's always a tendency in these communications to simplify the message and the belief that it makes it more understandable, but often it does the opposite. And so, as a rule of thumb, I suppose you can't go far wrong if you communicate that uncertainty, what is known, what is not known, emphasize that it might change as the science changes. People are quick, you know, they want to know, they want to understand, they want to know how to protect themselves. So don't assume that you have to fob them off to misleadingly somehow persuade them. Yeah, and I've seen that again and again.
Hannah, if you can hear me, did you have any final remark or response to any of the questions?
I'll just end briefly on this question of fake news to say that there's a very long history in anthropology of studying rumours, including around biomedical work and biomedical research. And what a lot of that work points to is that rather than being kind of expressions of ignorance, that rumours about problems that people face with how they see biomedical research taking place often point to some actually quite important kind of tensions between local communities and people who are implementing things, and they can often be a really useful source of information, not in terms of what people are ignorant about or what they need to know, but in terms of what kinds of changes maybe the response should think about implementing. So for example, in the Democratic Republic of Congo, there were a lot of rumours about people stealing money, and these were really linked to the kind of economy of the response and the way that it was being managed and delivered, and practices, for example, of bringing workers from Kinshasa to deliver a response the other side of the country, and jealousies and so on around, you know, the way that resources were being diverted. So, you know, obviously, we're really up against it when we live in a world where the Russian government is paying to create fake news stories about the presidential candidate and all the rest of it. So there's this whole kind of political economy that's really, I think, beyond the control of any social scientist. But I think this is another point, again, where anthropology allows us to kind of question the parameters of this so-called problem about rumours and misunderstandings, and ask, okay, well, you know, what does this look like from the point of view for the people who are kind of talking about these things and saying those things, and why are they saying them? Where's this coming from?
Thank you very much. So I'm going to close there, and thank you very much to all of you, and thank you to the audience. And there you are.